Dr. Rabo, you have the floor. You have 10 minutes.
Dr. Rabo, we can't hear you. Seem you're muted.
My senior colleagues, good morning, my teachers, good morning, colleagues. I'll be taking practice 5 today for the questions for today. So the question says the image is the radiographic image of a teenage female patient. So the question goes, A, list the components of the triad in this condition. B, how do patients present? C, give 3 possible ECG diagnoses. D, what factors determine clinical presentation? And E, what is the predominant arrhythmias encountered in them? So answering the first question, list the components of the triad in this condition. The 3 major components in this triad are the atrialization of the right ventricles, the tricuspid valve abnormalities, which consist of the adherence of the septal and posterior valve leaflets to the myocardium, then apical downwards displacement of the tricuspid valve. So how do they really present? I'm going to focus on the adult life because it's a teenage woman. So for presentation, they usually present with fatigue, exertional dyspnea, cyanosis, tricuspid regurgitation, or right heart failure. They can also have palpitation, arrhythmias, or sudden death. For the possible ECG diagnosis, they can present with tucked peaked P wave in lead 2 and lead 1. And it can also have giant P wave, which they have heights of greater than 5 mm. Complete or incomplete right bundle branch block is common. And it can also have supraventricular tachyarrhythmias. So what factors determine clinical presentation? So factors like age of presentation, if they present in neonatal life, adolescent life, or adulthood, severity of the functional abnormalities, severity of the anatomical abnormalities, and if they are associated with other congenital heart defects. So, was the prominent arrhythmia encountered in them? In this question, I don't know if it was arrhythmias or just arrhythmia, but the predominant arrhythmia is the supraventricular tachycardia with Parkinson-White pattern. So looking at a brief history of Ebstein anomaly. Ebstein anomaly of the tricuspid valve is a congenital malformation in which there is downward apical displacement of insertion of septal and posterior leaflets. It was first described by Wilhelm Ebstein in 1866, where he did an autopsy of a 19-year-old laborer who had cyanosis and dyspnea since childhood. Looking at the epidemiology, the Ebstein abnormality occurs in 0.3 to 0.7% of all congenital abnormality. It has been seen in 1 in 200,000 live births, and is more common in children of white females. It can present in various stages of life, and mortality at all ages is about 12.5%. A study was done in Maiduguri for 2 years between January 2021 and December 2013. And out of the congenital heart defects, 5 of them were discovered to have Ebstein abnormalities. So it can actually be common in our part of the world if we do more echographical diagnosis. So what's the etiology of this disease? Okay, so congenital disease is often uncertain cause. There are also some factors that have been found to be associated with it. We have the maternal injection of lithium in the first trimester, the use of benzodiazepine, previous history of fetal loss, and maternal exposure to vanishing substances, which carpenters usually use. Also, there are some genetic factors that have been implicated. Most notably is the NKX 2.5 mutation, 10p13 to p14 deletion. This has been described. And most recently, they discovered a gene, the MyH7 gene, where out of 8 patients, 6 of them were found to have Ebstein anomaly. Other associated defects with it is the ventricular septal defects, the atrial septal defects, the pulmonary stenosis or atresia, the PDA, the TOS, and some syndromes that have been associated with this defect are the known as the Marfan and the Down syndrome. Now, looking at the tricuspid valve anomaly to explain the pathophysiology. Now, the tricuspid valve annulus is mostly apical and caudally displaced valve with the highest orifice amongst the 4 valves. The tricuspid anomalus is oval-shaped and when dilated becomes more circular. It's larger than the mitral valve, about 20% larger, and measures to about 3 to 3.5 cm. Now, looking at the labeling, you can see that the septal and the anterior leaflets are larger, while the posterior leaflet is smaller, and it appears to be less functional of significance since it may be implicated without impairment of the functional valve. Now, the leaflets and tensile apparatus of the atrioventricular valve seems to be formed by a process of delamination of the inner layers of the inlet zone of the ventricles. Delamination occurs of the right ventricular free wall and continues to the level of the atrioventricular junction. However, in Ebstein anomaly, delamination of these leaflets may have failed to occur due to an incomplete understood mechanism. Now, this process of delamination is incomplete and falls short of reaching the level of the atrioventricular junction. The apical portions of these valves fails to reabsorb completely. Now, there are 3 several anatomical components of Ebstein's anomaly, namely the displacement of the septal and posterior leaflets towards the apex of the right ventricle. Anterior leaflet is usually attached to the annular level and is large and sail-like with multiple attachments to the ventricular wall. The portion of right ventricle that is proximal to the level of the displaced septal and posterior leaflets is called the atrialized right ventricle and is usually thin and dysplastic. The right ventricular cavity beyond the attachment of the septal and posterior leaflets is the functional right ventricle, and it's smaller, lacks inlet portion, and has a small trabecular portion. The infundibular portion of the right ventricle is sometimes obstructed by redundant anterior leaflet or this cordial attachment. So we can see the normal here. Sorry. So that's the normal and the Ebstein anomaly. Now, we can have various degree of severity of the lesion, as I said in the answers. And this degree of displacement of the tricuspid valve and the degree of tricuspid regurgitation. In the mild Ebstein, tricuspid valve function close to normal. While in the moderate to severe form, with each atrial contraction, the blood is propelled into the atrialized right ventricle. With right ventricular contraction that follows, the blood is forced back into the right atrium. Now, with the next atrial contraction, the blood is forced into the atrialized right ventricle. So you see that as these contractions are going on, blood is going back and forth to the right dilatation, to the atrium, going back to the right ventricle. Now, this right to left shunt can cross.
Yeah, just one more minute. We just try to wrap up.
Okay. So in severe cases of flow from ineffective right ventricular cause, this can cause physiological pulmonary atresia, and this can cause severe cyanosis and acidosis. So clinical presentation, since we are discussing adults, they can come with fatigue, exertional distance cyanosis, heart failure, palpitation, and arrhythmias. Now, for physical examination, I've said this before. So for heart sounds and murmur, they present with third to fourth heart sound, commonly called the quadruple rhythm, and it's the summation of the third and fourth heart sounds, especially with prolonged PRO that can mimic an early diastolic murmur. The systolic murmur of mitral regurgitation is usually of mild frequency and is crescendo in nature. For investigation, we can do for the investigations, in ECG, we can see a tall P wave, prolonged PR interval. We can have features of right bundle branch block, the supraventricular tachycardias, and the Wolff-Parkinson-White syndrome. Here you can see the giant tall P waves in lead 1. We can also see a bundle branch block in this image. For chest X-ray, it can be normal. We can have cardiomegaly, and the most consistent is the dramatical radiological feature of the right atrial soleus, which is almost always enlarged. We call it the boot-shaped sign. And these are different. So for echocardiography, this is actually the diagnosis, the investigation of choice, and it's actually diagnosed when we have apical displacement of the septal leaflets of greater than 8 millimeter of 8 mm. These are other Doppler studies we can do with the echocardiography, and we can also get the severity of the tricuspid valve using the Gauss score, which can be helpful in the classification. And these are how we classify it. We can also do a Carpentry classification where the type A is the true right ventricular volume is adequate, while for the type D, there's almost complete atrialization of the ventricle, except for the small infratubular component. This is about it. For the cardiac MRI, it is preferred for quantitative measurements and right atrial and right ventricular size and diastolic function. These are for cardiac MRI. Then we can also do cardiac catheterization. For the differentials, we have the Wolff-Parkinson-White, the ASD, the isolated severe tricuspid regurgitation. Management can be medical or surgical. For medical, we can use diuretics, cardiac glycoside, ARBs or ACE inhibitors, and antiarrhythmic agents. For the treatment, in patients with symptomatic arrhythmias or pre-excitation on ECG, is usually followed by ablation. Now, arrhythmias are preferably treated with ablation before surgery because following surgery, access to right-sided accessory pathways are slow and it can be hindered. For surgical repair, we have the recommendation for surgery people that have heart failure, exercise intolerance, and progressive diastolic function. These are also some indications for surgery, and also we can do a heart transplant. Heart transplantation is considered for patients with severe LV or severe biventricular systolic dysfunction. These are the complications we can get from the Ebstein anomaly, and these are the outcomes. So, thank you.
Oh, thank you so much, Dr. Rabo, for that beautiful, extensive presentation. Okay, so now we welcome comments and questions first from the participants. And please, let's keep the thanks coming on the chat. Let's keep the thanks coming. Okay, I can't see any hands up yet. A beautiful presentation. Any comments or questions from the participants? It's all thanks on the chat. Dr. Kalawama says thanks. Yeah. Okay, go ahead.
We have 2 hands up.
Okay, please, Dr. Onelo, please go ahead.
Good morning, teachers and colleagues. Thank you, Dr. Irabo, for the wonderful presentation. In addition, I wanted to mention another factor that determines the presentation of the patients, apart from the ones you already mentioned. One other factor, especially in adults, is exercise. Usually, the younger patients with or children with Ebstein's anomaly present with cyanosis, but this is not so common in adults. However, in the presence of, if the patient exercises, the cyanosis will appear. That's why sometimes they say they have intermittent cyanosis. So they have cyanosis with exercise. You know, with exercise, there's increased venous return to the right side of the heart. So normally this would not cause a right to left shunt in the presence of a septal defect. But when they exercise, this venous return increases, increasing the volume of blood that is present in the right atrium and right ventricle. And then with that, there's shunting of blood from the right atrium into the left atrium via an ASD or a PFO, causing cyanosis. So exercise is another determinant of their presentation. So in the presence of exercise, they would have cyanosis. And then another determinant, I'm not sure if you mentioned it, is the presence of supraventricular tachycardia. So when they have an accessory pathway, additional presentation they will have is palpitations. So that's my contribution. Thank you.
Oh, thank you so much, Dr. Nello. Okay, Dr. Conte.
Yes, thank you very much for a very detailed presentation. Yeah, I just wanted to add that the septal defects, atrial septal defects, are also associated with this condition, and that is what brings the complication of paradoxical embolism. As he rightly mentioned, the determinants of the severity of presentation, and the more apically displaced the valves, that the earlier they present with all the cyanosis. Now, one thing that we've seen in a few cases is that those who present late, okay, they tend to come with severe pulmonary hypertension, and that leads them to develop massive pericardial effusion. Recently, I had one patient that he was having recurrent pericardial effusion even after drainage. Within a week in the hospital, it has reaccumulated, and then we had to send him for a pericardial window to be able to, prevent the recurrent pericardial effusion. So that is one late presentation that we've seen in adults coming with severe pericardial effusion caused by the pulmonary hypertension that is associated with the condition. Thank you.
Oh, thank you so much, Dr. Conte, for that beautiful addition. Okay, so I think we have a few comments on the chat. Okay, so everyone is saying thanks. Dr. Caroline is saying thanks. Dr. Iruka is saying thanks. Dr. Abimbola says thanks for the presentation. Can age at presentation be a factor in determining the clinical presentation? Yes, he said that. Can syncope be a part of the clinical presentation? Then can SVT, with or without? Yeah, that he also mentioned that. Dr. Arabo, do you want to make a comment on the syncope part? And then the rest are thanks.
Okay, thank you for the comments. Thank you for the contribution. Thank you, Dr. Conte. Thank you, Dr. Neka. For syncope, yes, I saw it somewhere, but it was not in most of the text I saw. Usually, depending on the age at which they are presenting. For adult medicine, which we are doing, it was there in Medscape, but for the brown word, it wasn't there. For brown word, it was fatigue, exertional dyspnea, cyanosis, tricuspid regurgitation, right heart failure, palpitations, then all forms of arrhythmias. They can even present with even sudden death. I don't know, maybe that's what I saw. Thank you.
All right, thank you so much. Okay, so we don't have any other comments. I can't see any other hands. So, okay, sir, please go ahead. Dr. Kopi's hand is up. Sir, please go ahead.
Thank you so much, my brother Erabo, for that beautiful presentation. Thank you Conte and Onelum. I just wanted to comment on the syncope. They can actually present with syncope depending on the grading. Eraba, remember you spoke about the Carpentier grading. So for grade C and D, where the anterior tricuspid valve is fixed, in some of the patients, it will result in alveolar obstruction, just the way Conte said. Attention. And also the return of blood to the left side will be paired. So they can present with some form of syncope. But if they have additional septal defect, it may not present with severe syncope at some point. So depending on the Carpentier grading, and also you remember the Selemenga criteria, 4, 3, and 4. So at that level, they can actually have alveolar obstruction. So some of them can actually present with syncope. So I'm not sure if you spoke about, my network was actually misbehaving at some point. The etiology with respect to maternal exposure to benzodiazepine, lithium, volatile substances. Just to add to that in case you didn't say that. But in all, thank you very much. You did a wonderful job. Thank you. But I can present with syncope. Thank you.
Thank you so much, sir.
Thanks. Thanks, Steve. I'm sure it was the time you said your network was not good. I actually mentioned the exposure to vanishing substance, the injection of lithium in the first trimester, the benzodiazepine use, in previous vital loss, Chief. Thank you, Chief.
Okay, at this point, we'll go back to, I don't know if, Mark Christabel, I don't know if more of our teachers have a comment or two.
Thank you. Thank you so much. I'm glad Dr. Kopi came up. I must appreciate his speaker, Dr. Irabo. He did so well. He was eloquent and he kept to time. Thank you so much. For the cardiologists not to come for you, I know most time cardiologists seem to be quite united. Once they're doing any presentation, you see them contributing, commenting. So for them to be this quiet, it shows that you did a wonderful job. Even Fatima didn't have anything to add, showed you impressed them. So once again, Dr. Irabo, thank you so much. Dr. Kopi, if you had not spoken, I wanted to call you actually, because this is your exam too. You're also a cardiologist. So thank you so much for coming in to fine-tune all what he said. Thank you so much. Dr. Fatima, I don't know if you have any comments. Chief Chito, okay, Chief Ramigos, any comments before we move to the next question?
Hello, thank you, Dr. Christabel. My only comment is that it was a very beautiful presentation. I love the pictorials. It was the slides were well prepared. I just loved it. It showed that he took his time, dedicated his time. He came out to teach us, and he actually did a very good job. Thank you.
Thank you, sir. Thank you. So, Dr. Ekele, Dr. Rabo, once again, we appreciate you, all the commenters, Dr. Nelum, Dr. Kopi, I think some other person. So Conte. I really appreciate Dr.
He's a cardiologist too.
I know Dr. Nelum, Dr. Conte, they're both cardiologists. I must appreciate Dr. Conte. The guy has been quite active since he joined. He joined the class recently. Unless some people that will just be quiet. The guy has been, So Dr. Conte, once again, we appreciate you. Once you are doing well, we're not saying behind the class, we'll say it in your presence. It will be on record that we appreciate you. So thank you so much, Dr. Conte. So Nelum, thank you so much. I know her personally, wonderful person. So thank you everyone for this wonderful presentation. Dr. Ekele, we can move to the next question.
All right, thank you so much, Ma. Thank you so much again, Dr. Rabo.
Sorry, Dr. Christabel.
Yes,
Dr. Christabel.
Yes,
that Dr. Conte's voice is so there all the time that someone beside me is always like, this Dr. Conte, I like his voice. So can you imagine someone that is not part of our class?
That means Dr. Conte has a good voice. He has admirers. So it's good. It's good. Dr. Conte, once again, thank you.
That's some of the things you get in cardiology. It's actually a beautiful place to specialize.
Okay, let's hear what was all this.
See, why are you stressing yourself? Everybody here, they're all committing stem cells already. So you
Don't
can't,
mind Dr. Kopi, he likes
you can't
sprouting.
do anything. No, but Chief, cardiologists are doing well. They are doing well. They are doing well. I give it to them. Maybe because of their numbers, but cardiologists are doing well. I agree. I agree with Dr. Kopi. Thank you,
so much.
cardiologists. We appreciate you people. Can we go to the next question now? Thank you. Thank you. Thank you. Dr. Kele, please.
Okay, yes, ma. Dr. Adivoka, please share your slides.
Hello, good morning.
Good morning, Chief.
Yeah, can you hear me?
I can hear you. I can see your slide.
Okay.
Okay, so you have the floor. You have 10 minutes for the presentation.
Good morning, teachers. Good morning, senior colleagues, and good morning, colleagues. So my
Can you put
question
it
is...
on slideshow, please? Can you put it on slideshow?
So I'll be presenting on question number 6. So I'm Dr. Adivoka Gerald. So the question goes like this. A 25-year-old female university student was afraid she had sexual contact with someone suspected to have HIV infection. She went to a pharmacist and demanded PEP. She was given Trazivir, which she took for 1 month. 1 week after starting the drug, she presented with skin rash, sewn above with no mucosa involvement. So this is the skin rash. Actually, the question that was given to me, I look at the pictures, they were not really clear. Then I went in to look for the correct picture online. And this was what I found. In addition to that, I found another picture that looks similar in case the next exam, they happen to bring this picture because they move together. So you can have a look at it. This A and B. So they brought the B. So this is the picture. Now let's go back to the question. And the first thing, A, that says, describe the skin lesion and state the reaction. B, what other findings will you look for? C, what is wrong with the drug combination and how should the patient concern have been addressed? List the investigation you will do for the patient. What will be your approach in treating this patient? So in this question, we just need to look at some few things. There's a young female that presented to the pharmacist without any prescription and was handed over a drug to her, which was also which means that there was no referral to the pharmacist. And the other thing, that the drug combination that was given was wrong. So in looking at the picture, how do we describe the picture? And first of all, you have to look at the differential diagnosis that you are likely to see. In this case, the culprit drug here is nevirapine, which is usually one of the common causes of drug eruption. And the patient was given nevirapine in this case. Now, looking at the differentials, these are the things that you have to keep in mind. The patient might have nevirapine hypersensitivity syndrome or reaction, or nevirapine-induced rash with eosinophilia and systemic symptoms. In terms of describing the lesion, you can see that this patient has a diffuse erythematous mucopollular rash involving the upper trunk with multiple areas of vesicles and bullae on the upper arm. You can see, and it's limited to the upper arm, even though there are other mucopollular rash on the other part of the body. The face is not shown, but you can see that it's also extending to the neck. And the question is, with your culprit drug, what do you think? And what are the other differentials you have to consider? Looking at the duration, the close differential that we have to look at is xanthomatous drug eruption. You may also consider acute generalized xanthomatous pustulosis. Stevens-Johnson syndrome can also be considered. And then toxic epidermal necrolysis can also be considered. Now, the next question was to describe the lesion and stage the reaction. Now, in terms of nevirapine-induced drug reaction, usually it depends on the stage or the grade and then the severity. So when you have a patient who presents with grade 1, you have only mild localized macular rash. Grade 2, you have moderate diffuse macular and then macropopular or mobiliform rash or target lesions. And grade 3, we have severe diffuse macular, macropopular or mobiliform rash or target lesion with vesicles or limited number of bullae or superficial ulceration on mucous membrane limited to one side. Especially in our case, you realize that the vesicles and the bullae were limited to one side. And then the macropopular rash was also diffuse. And then when you have grade 4 or stage 4, you have life-threatening skin involvement where that would probably lead you to Stevens-Johnson syndrome or TEN. Now, what other findings do you look for in this patient? In terms of examination, the patient may present with fever. So the patient with fever, when you examine the patient, there may be lymphadenopathy, there may be hepatomegaly, there may be other signs and symptoms related to visceral involvement. And then the other important part is when you are looking at the full blood count, you may look at leukocytosis, eosinophilia, and then atypical lymphocytosis. Now, C says that what is wrong with the drug combination and how should the patient concern have been addressed? The first thing is that trazivir is a combination of abacavir, lamivudine, and zidovudine. The nevirapine was wrongly added to the combination, and which caused most of the reaction that the patient had. So, first of all, the patient shouldn't have been given that combination. Now you have to know that anytime you are giving abacavir in the VOP wall or where there's a testing to be done, you need to check for HLA-B 5701 before you can give the drug because of the side effects and because of metabolism and other genetic abnormalities. Now the concern here is the nevirapine in this patient. We know that usually nevirapine is contraindicated post-exposure prophylaxis because of the side effects. And now the newer PEPs are coming, they don't prefer using that one. And usually most of the patients, when they present with high CD4 count, it leads to a lot of complications. So you try to avoid that one. But the current post-exposure prophylaxis you have to look out for may include tenofovir, tracitabine, then you need to add raltegravir or dolutegravir for 28 days. And you know that anytime there's a PEP, you have to take the history and know when the patient was exposed. You need to take the drug within 72 hours. The earlier you start the drug, the better the prevention of the transmission of HIV. So after 72 hours, the drug may not be effective. You can also consider giving tenofovir, lamivudine with raltegravir or dolutegravir. And then there are other ones that are available. Now, the other question says, what should the patient concern have been addressed? What we need to know is that this patient just walked to the pharmacy. He wasn't referred from anyone and just demanded. And he demanded for the PEP and the pharmacy also just gave without asking any question. That resulted to so many things. So ideally, the patient would have been referred to a healthcare center and then testing will be done and then the right treatment will be given. But in this case, if you want to address this patient issues, one, you have to assess the patient eligibility. You need to ask when was the last time you had sex, whether the patient is even eligible to take the PEP. Is it more than 72 hours or is less before you can consider that? Now, if the patient is eligible, the question is you have to look at the risk of transmission. Was it high risk or it's a low risk? And then you have to also look at the risks and benefits of giving the PEP to that patient. Now, if you have assessed all this and the patient has qualified to take the PEP, what do you do? The second step you need to do is to do what we call baseline testing. This patient has just come, you don't even know where the patient has been practicing unsafe sex and that they have decided to go for the drugs. You need to test the patient to confirm whether it's HIV positive or negative before you give the PEP. Then you have to do Hep B, Hep C, and then you may have to do baseline liver function testing, and then BU and creatinine before you start the patient on the medication. Now, if all these things are normal, the next step you need to do is to select your prescribed PEP. I know that we have different types. you have the non-occupational PEP regimen, especially the exposure that you need to know. Now, if you are selecting, as this patient was wrongly given the combination, that led to the skin reaction, you have to also look at what is available and then you talk to the patient. After selecting your PEP, you don't leave the patient there. The next thing you need to do is to do follow-up, because this patient presented again with skin rash. If it was given at a particular facility and was cancelled at the right way, it means that you would have followed up and stopped the drug in time before the patient condition gets worse. So you need to do a follow-up and then be sure the patient even takes the drug. So adherence is very important. Otherwise, it will be useless in treating this patient with the PEP. So with all this, we will be able to address the patient concern and follow up and talk to the patient, advise the patient to practice safe sex. Now, and the other question is, list the investigation you will do for the patient. Now, this patient presents with skin eruption. And what do you do? First of all, you may have to do full blood count. Sometimes the full blood can help us to know, especially now that we are thinking of nevirapine-induced DRESS. So the full blood count may show leukocytosis and atypical lymphocytosis or eosinophilia. That will help you to point towards DRESS. You can do skin biopsy where you see interface dermatitis with basal cell vasculation. Sometimes you may also see spongiotic patterns, and then there may be vascular involvement. There are other inflammatory markers we need to do. But for you to exclude other diseases, you know that one of the causes of DRESS is the herpes, the human herpes virus, especially HHV6. The other one is virus, cytomegalovirus can also lead to that. You may have to rule out that before you start thinking that it's only your drug. In our setting, we know that Hep B, Hep A, and Hep C in acute infection.
Just 1 more minute. Maybe you should begin to round up.
So you can lead to all this manifestation. Then you can exclude other organ involvement, liver function test, and then creatinine for the renal involvement. Now, the last part of the question is, what would be your approach in treating this patient? Now, first of all, this depending on the severity of the disease, it's a multidisciplinary approach. You need to involve the dermatologists, you need to involve the hematologists, you need to also involve the hepatologists, nephrologists, and this patient must be managed at the Benz unit, ideally at isolated room, so that you prevent contamination or superimposed skin infection. Now, first of all, you need to do drug withdrawal. So as we are withdrawing the drugs, you don't introduce that we call paradoxical activation of other drugs and that. And the other one you need to do is supportive treatment, which is very important. The monitoring and prevention. With supportive treatment, you have to give IV fluid, check for electrolyte, nutritional support. Some of the patients, you need excellent skincare with using the emollient and warm bath and then dressing to prevent skin drying and other that. With mild disease, with that present with pruritus, may involve skin inflammation, then you have to do topical steroid. Then with the severe disease, systemic steroid may be involved. You can use prenixalor, methylprenixalor for 1 to 2 weeks, and then you taper down. And then second line therapies can also be used, such as cyclosporin, azathioprine, and then sometimes some of the patients you may have to use intravenous immunoglobulin, and there are other agents available. So in this case, just to look at introduction of rash, nevirapine is widely prescribed for HIV, and we know that it can lead to skin, can lead to conditions like DRESS, and then later on Stevens-Johnson, and then TENS. So you have to take note of that. And the reason is that nevirapine actually, principally, is cleared through the cytochrome P450, and then because of other drugs that are used the same pathway, there's metabolite toxicity, and some of them too may involve the same pathway, and most of the patients that comes with that may have a lot of toxicity and side effects. And then with DRESS, we know that it's common sometimes with admitted patients. You have to look out for any patient that comes with skin rashes, and then with exposure to some particular drugs, especially when you have the anticonvulsant medications. And risk factor for DRESS is drug exposure, like what our patient had, viral infection, and then we have pharmacogenetics or stability. This is just to summarize what I'm talking about. You need drug exposure, you need viral reactivation. Genetic can lead to all this. And the part of it is just about T cell activation. So CD4 and CD8 T cell activation that will lead to the skin manifestation that you are seeing here. So you can see the lymphadenopathy, the fever, the interface dermatitis that will lead to the skin rashes that we have seen in this patient. And whether there's another pathway where the other organs can be involved, that will give you hepatitis, acute T-cell nephritis, and then you can even end up getting autoimmune thyroiditis type 1 diabetes. So the other clinical pattern is latency phase, where you start with the drug and then the rashes start occurring, then you move to the systemic involvement. So the grading, I've already made mention about that in case you are looking at nevirapine. And then in terms of diagnosis, it's just diagnosis sometimes is clinical. So you need your clinical, you need your liver, your full blood count, and then you have to also do skin biopsy if it's possible. So there are so many diagnostic criteria that you can use. You can use the Regica study that is usually used by the Europeans. Then we can use Japanese consensus group, and then there are other ones available. So you need 3 of these to make a diagnosis. Then you need 7 of these to make a diagnosis, depending on the criteria you use. In terms of management, we know that drugs usually involve drugs. So you suspend the drug, and as I said, multidisciplinary approach. You need to treat the patient if there's fever, and then if there's pruritus, you use antihistamine medications, then topical steroid, and then other medications. And you have to avoid NSAIDs and antibiotics that may precipitate more reaction. In terms of non-severe address, then you can monitor the patient, but when it's severe, you can use prednisolone, as I said, methylprednisolone for 4 to 6 weeks, and then monitor the patient. There may be other options to use, other ones, especially if the patient is not improving. And if it is being caused by the viruses, then you have to give ganciclovir and then valganciclovir to help the patient. So these are my references. Thank you for the opportunity.
Thank you so much, Dr. Adiboka, for that extensive, very lucid, beautiful presentation. Okay, so we'll take comments from the participants first, and please let's keep the thanks coming on the chat. We'll take comments, questions from the participants. Very detailed presentation. Okay, I can't see any hands. Okay, there's a hand up. Chief Mahmoud, please go ahead.
Thank you so much, sir, for the presentation. It was quite lucid. Please, I just wanted to ask why you're stopping the nevirapine. I don't know, because what we typically know is when there is much mucosal involvement, it could be an indication to stop the NNROTI. I don't know why we're stopping it here now. Please, I would need clarification on that. Thank you.
Yeah, so at first, we used to wait for the viral load to come down before we start the treatment of antiretroviral medication. I know nevirapine is associated with skin rash when the CD4 count is high. And now we are preaching test and treat. So most of the patients that come with HIV, you have to start the treatment. So if you start a patient with nevirapine on high CD4 count, the patient is likely to come with skin rashes. So because of that, it's advised that you avoid those ones. That's why the newer drugs are being made available for usage. And usually when you are giving nevirapine, what they do is that you have to start gradually. So you give 200 milligrams daily for 2 weeks, and then see whether the patient is reacting. If the patient is not reacting after 2 weeks, then you do 200 milligram BD to avoid the side effects.
Okay, if you are to start, if you are to now maybe change this nevirapine, which would you change to as an add-on that will have a lesser side effect? Let's say there's need to treat and you need to continue with the drugs later.
So if you are going to use the same regimen, the best regimen now is to replace the nevirapine with abacavir in this patient that we had. So, but of late, because of the newer drugs, the integrase inhibitors, we don't use nevirapine again as PEP. So we now use the tenofovir, lamivudine, and then the dolutegravir as a TLD that we know. So in this case, it's a combined combination, and it's once a day for 28 days.
Thank you.
Thank you so much.
Sir.
Okay, so okay, let me just add this question. For the grading you gave, is it just for nevirapine induced stress or for other drugs too?
So this question was actually, it was specific, and that is why I came across with this one. There are other grading in terms of the drug use. You know, most of the drugs that we see depends on the drug. You can have allopurinol dressed, you can even have other drug dressed. So with nevirapine, this is what was graded and in our patient, but there are other grading that you look that are there.
All right, thank you so much. So we have a few comments on the chat. So a lot of thanks, Dr. Sori says thanks, Dr. Miki, Dr. Kalamama says thanks for the presentation, Dr. Itonha. And then Dr. Adeyemo Adedapo says, thank you, Chief, for the detailed presentation. Depending on the stage of the disease, signs can be found include Nikolsky sign and as Bohansen sign. Also, the patients could be screened for HLA-B57 and HLA-DRB1. Okay, thank you for that comment, Dr. Adeyemo. Dr. Yahya Mohammed says, regarding giving nevirapine, that you said it's good to check for HLA. Okay, I think you mentioned that. I thought it was a Abacavir that requires HLA testing because of the fear of fetal hypersensitivity reaction that could occur. Does it mean that nevirapine, that even nevirapine, there is a recommendation for that? Would you like to please react?
So there are some high risk patients, especially the Asians, Africans, they have high risks of having nevirapine, skin rash. So elsewhere where the means is available, it's advisable you check for that. That is why the risk factors are genetic or pharmacogenetic variability. So where the means is available, you need to check.
Okay, thank you so much. Okay, Dr. Mahmoud, is it the old hand or you have another comment? Okay,
Sorry,
so thank you. Okay, so I can't see any other comments or hands up. Okay. Ma, I don't know if our teachers, I don't know if our teachers have some comments. Ma Christabel.
Dr. Ekene, thank you so much. I want to call on the dermatologist in the house. Dr. Awa, any comment from you? Dr. Ifoma, Dr. Diola, any comments?
Yeah, good morning, class and the house. This is Dr. Dike on the line.
Thank you, Dr. Diola. Please, can you have any comment, please?
Okay, yeah, the presenter did very well. He's actually nevirapine in distress, and I think he attempted the questions beautifully. Practically, the way we would have approached it if we had the questions. Then he was right by saying that nevirapine is not an option to use because of these problems. For post-exposure prophylaxis, is not used. Yeah, for PEP, and that's what the patient has come down with these complications. It's not a routine drug use for this particular condition. So you attended the question. I don't have any addition. Thank you.
Oh, thank you so much. Thank you. Dr. The presenter, what's his name? Dr. Gerard. Oh, it's easier.
Yeah.
Dr. Gerard, thank you so much for a wonderful presentation. Please, can you just highlight the management? There are quite a lot of theoretical aspects. Your presentation was wonderful, by the way. There were a lot of stuff, but can you just highlight how you manage this patient? In summary, just summarize how you manage your patient, the key factors.
So the main important thing is a multidisciplinary approach. So you need to involve all the teams. 2, you need to withdraw the drug, because in this case, nevirapine was involved. Any drug that is involved, you need to withdraw the drug, and you have to avoid using newer drugs, or it may worsen the case. And with the supportive treatment, most of them come with extensive skin involvement. Skin care, very important. Fluid loss, they can go into sepsis, shock because of the fluid loss. So you need to take care of the skin. That's why you need to manage the patient at isolated unit and then avoid exposure to everyone. And in terms of the pruritus, most of them come with extensive pruritus. You can use topical steroid to help the patient. Then those that come with severe infection involving organ, especially the liver is the organ that is involved more. So with your investigation, that will tell you the stage of the liver damage. Sometimes there are some few cases that when I was reading, came across, someone had to undergo liver transplant. So with this one and acute intestinal nephritis, you need to look at all these ones and manage the patient accordingly. So you hydrate the patient, use your systemic therapy, and then you need to involve the specialist in terms of managing the patient. And the last part is because it's a drug and the patient, sometimes some of the patient walk into the pharmacy and then just buy the drug and get the reaction. You need to talk to the patient, advise your patient not to go in for any drug, a similar drug. But as you are exposed like this, you have high risks of exposure to any other drug that is similar to that. So you need to advise your patient on that, and then you monitor them so that when they have any other issues, they just come straight to the hospital. Then go into the pharmacy.
Okay, thank you so much, Dr. Gerard. That was a fair attempt. The dermatology, the skin management, I wasn't so happy with the skin management. That's I wanted you to highlight it again, just in case I was the one that missed it. You did well, but most of these stations are manned by specialists. If you just say this to dermatologists will not be impressed. Most time we are very skeptical in giving topical steroids. I don't know, most of us feel that all dermatologists do is go for steroid. We rarely do we. That's most time one of our last options, except it's an inflammatory condition. So we are not really so happy with topical steroid, oral steroid, and the rest. We're not so eager to give it. So first of all, for the itching, it's not topical steroid you give. A lot of antihistamines. There are drugs we give, and mostly the antihistamines, they come in here for that help to take care of the itching this patient have. But remember, this is quite extensive. It's quite extensive, and I don't know from your presentation, you mentioned some oral lesions. So that means they're going to be oral care, antibiotic, mouthwash, chlorhexidine mouthwash used at least 12 hourly. That will really help the wound to heal and also prevent infection, secondary bacterial infection. Then also you talk about the skincare itself. This skin, they are usually very dry and irritated. So instead of talking about topical steroids, you talk about moisturizers. Our dear petrolatum, like e.g. blue Vaseline, the blue sea Vaseline is a good one. Mineral oil, a lot of them, shea butter, but all these things have to be as inert as possible because you do not want to irritate the skin. Then they have abrasions, superficial ulcers. That's where topical antibiotics will come in. Things like mupirocin, they will have to come in. We rarely do topical steroids, except there's an indication, a strong indication for it. Then also input output. You want to, those that are shedding skin, you want to weigh those skin that are shedding daily. You want to know their weight. Because now we talk about high protein diet. Now, when they're shedding skin, they're losing keratin. Keratin is a proteinous element. So that will give you an idea of the least amount of protein you should target. If they're losing like 10 grams of protein every day, you should not go, when you're giving them 6 grams of protein, you are under replacing what they're losing. So, I know one thing too in life is if you get 10 grams, that means they lost up to 12 because it's not all the skin shed you were able to collect and weigh. So least you can give for such patients, the replacement for protein has to be at least 10 grams. So you weigh them daily, not just for protein replacement, but also to help you to know if they're responding to your management or not. If at the initial time of treatment, you were getting 4 grams daily, then as the days progresses, you're getting 12. That means your patient is doing poorly. patient is not responding to treatment. So from 4 grams, you start getting 3.5, 3 grams. Say, wow, patient is doing well. That will help you to monitor your patient better. Then also, if there are genital lesions, there is also genital care. You have to care for those areas too. Because one, that area can be infected. It can lead to adhesions later on if it is not properly cared for. So that one also have to come in daily cleaning with with normal saline. If you need to put these dilators there to prevent adhesions, you have to do that. So you have to clean it properly, then put moisturizers, that inert moisturizers, or you put Vaseline in impregnated gauze and just put it in those areas to enhance wound healing and also to prevent adhesions later on. Then input output is important because one, you want to know the fluid that are losing, you must replace it. AKI is also a common complication if it's not properly, if the fluid management is not properly then taken care of. So, but remember, in some in the skin, remember for the itching, antihistamine, the moisturizers, which can come is the petrolatum, our dear blue silver stain, then the oral care, then the genital care, the mucosa care. I hope that's fine. So thank you so much once again, Dr. Gerard. You speak like a Ghanaian. Are you a Ghanaian?
Yes, I'm a Ghanaian.
You speak
Thank you
like
so
one.
much for the comment. Yes.
And thank you. It was a wonderful attempt, really. You did wonderfully well. Just bringing up the practical aspect, because sometimes these things are manned by dermatologists. Once that's the way you speak, you're like, wow, are you a dermatologist? Don't know that you were trained. So please keep it up. I know you are new to our platform. Want to encourage you to keep speaking. And after you pass your exams, please keep coming back to encourage those behind you. And once again, thank you so much. I don't know if any of our facilitators have anything to add, any comment.
How can someone add when you have finished everything?
Chief Remeke, sir. Thank you, sir.
How can someone add when you have finished everything? There's nothing to add again. Meanwhile, you just reminded me of Ebenezer. Where is Ebenezer self?
Ebenezer, these are Ghanaian brothers. They are missing in action. No,
Hey,
that's
boy,
why I'm
we need to look for him or he should come back here.